Hi, everyone. This is Dr. Anuradha Singh. I'm here pleased to join with Dr. Natasha Acosta Diaz, who is our pediatric epileptologist. I want to thank the audience who are here today to join us and get more education about women with epilepsy. Um, Natasha, we are going to, after this slideshow, we are also going to be joined by one of my patients who has volunteered her time. So let's get started. Take it all from me.
Thank you so much, Dr. Singh. It's my pleasure to be here with you and sharing this webinar, where hopefully we're going to be able to, give some good education and journal our patients with a lot of master and knowledge. And do you want to start? You want to wait a couple of minutes?
We can wait a couple of minutes. Ankita is also our panelist. Ankita, let us know when we can start. Maybe have more people join us. I think we should get started, respecting everybody's time.
Sure. So during this webinar, this is part of the contents that we're planning to cover. We're going to talk about epilepsy and seizure, stigma, what happened during puberty, catamenial epilepsy, contraception, fertility, pregnancy, parenting, osteoporosis and osteopenia, and bone health. And as Dr. Singh mentioned before, we have one of her patients that is going to join us as well. And at the end, we're going to have some time for questions and answers, okay? We don't have any disclosure. And, I'm starting this webinar with this picture, and whoever knows me know that this is a picture of my family. And, my husband is there. He takes like half of the picture. And our 4 daughters are in the picture as well. And I didn't choose the picture just because we look very nice. It's because there's a 7th person in the picture. And that 7th person is somebody that is very special to us, and it's my niece. And the reason why this picture is the beginning of our webinar is because my niece was diagnosed with epilepsy during puberty. And, as many of the patients that are connected in this webinar, she was very tractable. She required to be in different medication, and she has to face some of the things that we at daily live with our patients with epilepsy. Like, she has had side effects from medication. But I just want to point, like, if you don't know me and you don't know which are my daughters, you cannot point and choose who is my niece. So we all have somebody that is very special in our life that is dealing with epilepsy. And I really want everybody to be very supportive of patients with epilepsy. She's having a healthy life and she's still taking medication, but overall she's doing much better. But she has had some side effects from some of the medication that she's taking. With this, we're going to start. And I feel that we first should say, what is epilepsy? Epilepsy is a brain disorder and is characterized because of seizures. And those seizures are unprovoked. And, for us to make a diagnosis of epilepsy, you need to have at least 2 seizures, and this seizure has to be at least 24 hours apart. As a pediatric epileptologist, I mention a lot unprovoked seizures to make the diagnosis of epilepsy, because we see frequently children less than 5-year-old that has seizures with fever. This is not epilepsy. Those are febrile seizures. And what is a seizure? A seizure is a sudden electrical disturbance in the brains that has symptoms, and depending what part of the brain this electrical abnormal activity is, you can have a convulsion, you can have involuntary jerking, you can have confusion, loss of awareness. There are some patients that are having seizures and is spacing out or staring off episodes or shaking or tingling. Today, I saw a kid in clinic that didn't know that those tingling episodes were part of her seizures, or the ones that we see in the TV where the patients collapse to the floor and they're having jerking and involuntary movement. So different presentation depending on what part of the brain is being affected. And this is just briefly just to mention what International League Against Epilepsy classify depending on the type of seizure. And we have seizures that are focal onset, we have generalized onset, and we have the ones that we don't know. And the focal can be focal aware, focal impaired awareness, focal aware motor or no motor, or the focal to bilateral tonic-clonic. And I really feel that every patient should know what type of seizure they have, okay? Just few words about epilepsy syndrome. As a pediatric epileptologist, we do see some patients that have a specific clinical and EEG manifestation, and they are grouped in a specific epilepsy syndrome. And it's very important because there's a specific treatment, prognosis can be different, and we know what can happen with some of these patients. And the International League Against Epilepsy recognized more than 20 different epilepsy syndromes, okay? So when we have a patient that we think is having seizures and we're making a diagnosis of epilepsy, we do an EEG, and I'm sure some of you have had an EEG, and the EEG can be very short. We can do a more prolonged study. Sometimes we do the EEG and the patients go home and the study runs from home. Sometimes we admit them in our epilepsy unit. Then most of the time we get as part of the work a brain MRI, but we can do different other imaging as well, depending on the case. And now more often we involve genetics, and we send a specific epilepsy syndrome. And in pediatric, frequently we also send a whole exome if there's other features in the patient. So the workup depends, is very individual, okay? So epilepsy affects more than 1.2% of the total US population. And we do know that there's a higher prevalence in the developing countries. And it's interesting because more than 1 million of women of childbearing age are suffering from epilepsy. So we are doing this webinar because there's so many things that we want our patients to be aware of. The sex ratios and epilepsy is not clear established, and we do know that it's non-discriminatory, so it affects both sex. And but there's a specific epilepsy syndromes that you can see more in girls than in boys. And I have to mention, as a pediatric epileptologist, the idiopathic generalized epilepsy, and there's one that is called childhood absence epilepsy. And this one is seen 2 to 5 times more in girls than boys. And I also have to mention juvenile myoclonic epilepsy, which is seen 1.5 times more in adolescent girls than boys. It's interesting the stigma that still these days is in patients with epilepsy, and I feel like more in women with epilepsy. And in several developing countries, there is still evidence of social stigma that is attached to women with epilepsy. In Nigeria, for example, I reviewed a study where they compared the regular women with epilepsy, and they all have like a worse social and economic status. And it's very sad for us that these days we're still facing these things. In India, there's more than half of women with epilepsy that conceal their history of epilepsy prior to their wedding, and feeling like a social stigma and the breakdown of the marriage. And I'm sure it's in specific places, but it's interesting to know that women with epilepsy, they experience changes in the seizure frequency and the severity in relation to different phases of the cycle that we're going through. So I'm going to start this webinar talking about puberty and what happened during puberty. And I feel like all of us that are connected in this webinar have already passed puberty, which is the process of physical changes through which a child's body matures and becomes an adult body that is capable of the sexual reproduction, right? That's the goal of puberty. And it starts by hormonal signals that start in the brain, and it goes on into the gonads, and in women's is the ovary. And this is what leads to the development of the secondary sex characteristic. I'm not going to go in details about this slide, but we do know that in the hypothalamus, the gonadotropin releasing hormones go to the hypophysis, or the pituitary gland. And this is where the FSH and the LH are produced, and they go directly to the ovary. And the 2 important hormones that I'm going to mention today is estrogen and progesterone. And this is an A6 that has a way of inhibiting, there's other hormones that are produced. And we do know that the cycle in a woman has fluctuates the level of the hormones during the menstrual cycle. And with this, I have to mention that puberty can be a common time for epilepsy to start. And it's multifactorial. We don't have a clear reason of why, but we do know that there's at least 25% of the women with epilepsy that they mentioned that their first seizure started during menarche. And there's a specific genetic syndromes that will present during puberty. And I just mentioned two in the past, juvenile absence and juvenile myoclonic epilepsy. This epilepsy syndrome start during puberty. But I have to mention as a pediatric epileptologist that there's a specific childhood syndrome that improved during puberty. And in that group, we have childhood absent epilepsy, and we have the group of self-limited epilepsies that in the past, they used to be called benign epilepsies because mainly we knew that patients tend to outgrow it by puberty. And this is a table where I'm just mentioning some of the common syndrome that we see in childhood and adolescent and the age of presentation. We mentioned childhood absent epilepsy that start in childhood, and these patients tend to outgrow the epilepsy by puberty and adolescence, which is different than juvenile absence epilepsy that tends to start during puberty. And same with juvenile myoclonic epilepsy that tends to start by puberty. And others like epilepsy with generalized tonic-clonic seizures can start during childhood or during adolescence. We're going to talk a little bit about the changing hormone levels in the body that can affect women, and some women and not others. And this graph, I'm going to show a couple of times, and this is a menstrual cycle. And we know that the menstrual cycle in regular women has a length of 28 days. And the first day of the menstrual cycle is the first day that you see your period. And this is very important because next I'm going to talk about catamenial epilepsy. So this is what happened with the two important hormones that I mentioned before, which is the estrogen and the progesterone. During the menstrual cycle, your progesterone goes down, and that's when you have your period. And then by day 14 is where the ovulation happens, right? And you need to have at least 2 cycles to be able to predict what's going to happen, because sometimes you have to count backward, right? So 2 important hormones that I'm going to keep mentioning during this presentation is estrogen and progesterone. We know that estrogen is a proconvulsive, and this can lower the seizure threshold, meaning that it can increase the interictal discharges, which are those abnormal waves that we see on an EEG that put you at risk of having seizures. And they have done animal studies where they inject estrogen and they see how the abnormalities on the EEG increase. And then we have the progesterone, which has some properties that are anti-convulsive. So if you want to remind this, a good way is like with the E of estrogen, we think that is excitatory to the brain. So it makes you more prone of having seizures. And progesterone is your protective hormone. With the P of protective, it protects you from having seizures. So we're going to talk about this catamenial epilepsy, which is very important. And I feel that every woman that has epilepsy should be aware of this. And these are seizures that are linked to the women's cycle. And it's interesting how frequent catamenial epilepsy can happen. And there's some studies that talk about up to 60 and 65% of women can have catamenial epilepsy. And it's very sad when we're seeing patients in clinic that are not even aware of this. And there's 3 patterns that has been well described with catamenial epilepsy, and they are called C1, C2, and C3. C1 pattern is during the perimenstrual period. The C2 is during the periovulatory, and the C3 is during the whole luteal phase. And this is mainly in women that have anovulatory cycles that I think Dr. Singh is going to talk more in the next couple of slides. How do we diagnose catamenial epilepsy is interesting. Like, there's no other clear explanation of why this seizure pattern is established. But the best way is that we have to work with the patient, and the patient has to keep a track and a journal of the seizure and the menstrual cycle. There's some doctors that recommend measuring your body temperature, because you know that during ovulation, your temperature goes higher. There's some patients that use some tracking like LH tracking that knows when progesterone is higher and know that they are doing during the ovulation cycle. But the most important thing is that we see at least a 2-fold or greater increase in seizure during those specific part of the menstrual cycle. Meaning, if a patient tend to, you're keeping a track of your seizures and you're keeping a track of your menstruation as well, and you realize that normally you tend to have more seizures during a specific part of the cycle, is a way of making the diagnosis. And remember that I talk about 3 different C1, C2, and C3. I go back to this slide that I showed you before when I was just talking about the regular menstrual cycle. And again, the perimenstrual start 3 days, and that's how you see that the numbers of days go from positive to negative. So this is, you start your period here. So 3 days before your period, you see how the progesterone that we already mentioned, that is the protective, how the progesterone drops. And this is the most common type of catamenial epilepsy, the perimenstrual one. Progesterone drops. Then we have the ovulatory C2 catamenial epilepsy, where you have this raise in your estrogen, which is the red line. And then this is your luteal phase in a normal cycle. And this is in patients that have anovulatory cycles, where the C3, the third type of catamenial epilepsy, can be seen during the whole luteal phase, because we know that progesterone is low, and this is part of the anovulatory cycle. So 3 different types of catamenial epilepsy. Then what is the treatment? Like, we already were able to keep a track, we're able to notice this pattern. What do we do? Sadly, there's no clear or FDA-approved treatment for catamenial epilepsy, and there are no clear guidelines, even though we're able to identify the increase on seizure. There's different things that we can do and that we try to do, and sometimes we discuss with the GYN as well. One, there's the non-hormonal and there's the hormonal treatment. In the non-hormonal, the recommendation of using clobazam, which is Onfi, and you can use this medication for 10 days, starting 2 or 4 days before the menstrual phase, and because that's where you have the C1, the premenstrual worsening of seizures. However, a lot of doctors don't like to do this because there's a huge risk of having rebound seizure whenever you stop a medication like Onfi. There's other medication as acetazolamide, there's like hormonal treatment like progesterone. So there's different things that we do, but there's nothing that is clear that is gonna help. We're gonna talk about contraception, because we do know that 40% of pregnancy are not planned, but if you're planning to avoid getting pregnant, we have to be careful of what medication we're using, and that's why we're here as well to help. In general, this is the failure rates of contraception, not for patients with epilepsy or for patients that are using any hormonal, any anti-seizure medication. So we do know that the female sterilization is the one that has the lowest failure rate, but this one you have to be ready that you don't want to be pregnant. But if you're using oral pills, the failure rate is like 6.9%, and with the IUD that we recommend a lot is 1.6% of failure rates. And I'm just showing you this, and this is without interaction with medication. This is just in the regular population. So please avoid the traditional methods if you don't want to get pregnant, because this one is a 78%. If you're planning to get pregnant, then it's different, okay? And I'm showing that because I want everybody to be aware of what happened with some of the anti-seizure medication that can impact the birth control. And we have what is called enzyme inducer medication, and it's just because of the way of this medication being metabolized in the liver. And enzyme inducer medication has a strong interaction with your birth control pills, meaning that it decreases the level of the birth control pills. And it's very sad, because you can have a young patient that is very irresponsible because they don't want to get pregnant, and they are unaware of this interaction, and they get pregnant and they don't understand what has happened. So in that group, we have carbamazepine, oscarbazepine, which is a trileptal tegretol that we use so frequently, perampanel, phenobarbital, phenytoin, primidone. This medication has to be taken very carefully when you are using when you're taking birth control pills. And it's interesting because in underdeveloped countries, these are the medications that are most commonly used. So you can imagine the interaction that this patient has. So you have to counsel, patient has to be aware that they need to use a second method if they're trying not to get pregnant, or a different method that is not based on hormones, okay? Then there are other drugs that we use frequently for epilepsy that they don't have so much interaction as on people. There's a mild interaction as well, so patient has to be aware. And then the good thing is that there are great medications that don't interact with your birth control, and that's why we have to be aware of the plan, and we have to work together with our patient like that. That is a discussion that has to be taken with us as well. And in that group, we have levetiracetam that is so commonly used, ribaciratem, gabapentin, pregabalin, sonizumab. So there's lacosamide. There's some medications that have minimal interaction with your birth control pills, okay? Then this is a common question that we get, and it's like, when I'm taking a birth control pill, is this gonna affect the medication that I'm taking? And we have to mention that this is common in patients that are taking lamotrigine. And again, lamotrigine is a great medication. Dr. Singh is gonna talk more about that because it's one of the safest medications that we use in women. And patients have to be aware of this interaction, because taking birth control pills or using the vaginal ring or estrogen patch can lower the lamotrigine level. So, if you were well controlled and then you start using birth control and suddenly you have a seizure and you're feeling so sad because you don't know what happened, it's mainly because of that interaction making the level of lamotrigine goes really low. So those are things that we have to discuss. And then there's a group of other methods that we can use that are not enzyme inducer. And in that group, we have the depot shot, and we have the IUD, and there's different IUD. We have the copper containing. And even though they have progesterone, that progesterone does not go systematically, so it does not affect the medication that we're taking. My last slide, I want to mention as well what happened with transgender that are part of the gender affirming healthcare. And this involves the hormonal and other treatment to match a person's physical and physiological sex characteristic with their identified gender. And again, most of these treatments are based on hormone, and we just mentioned how hormone can impact the seizure frequency. So in trans men, which is the female to male transgender people, they use the testosterone and other treatment to suppress menstruation and decrease estrogen levels. It's interesting because trans men that has a history of a catamenial epilepsy, they can do better when we decrease the estrogen. And then we have the trans woman, which is male to female transgender people, which use anti-androgen treatment to suppress the testosterone production in addition to the estrogen therapy. But we have to be aware, patients have to be aware of this anti-seizure medication and the potential interaction with hormone treatments, Remember that the estrogen will decrease the concentration of lamotrigine, as I just mentioned before. And as I just said in a couple of minutes ago, the cessation of menstruation in trans men can help improve the seizure in patients that has a catamenial pattern. With this, I'm gonna let Dr. Singh guide us through fertility.
Thank you, Natasha. Thanks for covering all these important topics, that how, some of the girls have specific syndromes and they outgrow those epilepsy and they don't have to remain on medications for the rest of their life. And some of the relationship issues and fertility issues that, girls or young adolescents face with. So I'm going to focus more on adult population. I hope it's a smooth transition from yours to my slides. So we really didn't have any evidence in the past that whether, fertility rates are affected by epilepsy or not. In the last 15 years, there has been quite a number of studies which have been very, very encouraging, which basically tell us that the birth rates or the fertility rates, which are different, because, if a woman who is who has epilepsy doesn't want to have pregnancy for whatever myths she has, versus if she plans whenever her seizures are under better control and want to get pregnant, versus the fertility rates. And there have been, recent evidence that really these women who are have epilepsy, if they are on appropriate medications, anti-seizure medicines, then there is really no difference in achieving pregnancy, despite the fact that, is there a decreased incidence of ovulation, as Dr. Diaz was mentioning, that there, in certain older medications, if you take, there can be something called, anovulatory cycles, that you do not get ovulation and you have less chances of having implantation of the fetus. There are certain drugs which are notorious to cause what we call polycystic ovarian syndrome, which is not like just your ovary has more cyst, but it is also associated with lactation, with some hair growth, with infertility, as well as cycles which lack ovulation. Some of the older medications and the issues that you mentioned, that in some countries compared to USA, we are talking about that they really don't have the newer anti-epileptics. They cannot afford it. They don't have access to it. So we are still dealing with the older medications, which definitely have proven in several studies that they have reduced fertility. Things like primidone or phenobarbital or dilantin or tegretol, these can definitely interfere with the female hormones. But the miscarriages rate in the recent studies, we have seen that it's pretty comparable to the general population. So, we always make joke of it and tell our patients that once you tell your husband that you're pregnant, the next person that you should go to and declare your pregnancy should be your epileptologist. A lot goes into the preconceptual planning. So when I see a patient and she tells me that I'm seizure-free, Dr. Singh, I don't have much to do except, taking that 30 minutes of my time to educate the patient that whenever she is in that right life cycle and she wants to conceive, she can definitely have healthy children. And I will never forget one of my patients in my older institution literally held my hand and kissed it when I told her that your other neurologist in New York City was absolutely wrong in telling you that forget about getting married, forget about having children. And she really wanted to have a kid. And so I think we can, as physicians, can do a lot in educating our patients so that the pregnancy is properly planned. Most of these patients, they should not walk out of the clinic without holding a prescription for folic acid. And I'll show you some of the data because folic acid supplementation is useful in combating some of the birth defects that the anti-seizure medicine can cause. It's a myth that stop your medications right away. There are certain medications that you don't want to be on, but stopping medications after you find out that you're pregnant is a no-no in my books. Frequent follow-ups may be needed in patients when they get pregnant because the drug levels of the medicines need to be monitored more quickly. Usually we monitor these drug levels when somebody has side effects, somebody has breakthrough seizures, or if the previous results were, showed some concerns. And if I'm worried about that my patient is not taking medicine and I want to check their compliance and try to check the blood level. But in females, the way the hormones change the drug levels, they need more close monitoring. There are many other things. In the first 3 months of pregnancy, you have all this nausea and vomiting. Not everybody suffers from nausea, vomiting in the first trimester, but those who do, they are taking their medicine, but they're not going to absorb it. Sleep deprivation becomes a big thing in the third trimester when patients, bladder is all, full and compressed by the enlarging uterus and they are using the restroom every few times in the night. So sleep deprivation, whatever stress level, all that anxiety of going through the labor, these are the reasons which can cause breakthrough seizures. So the anti-seizure medicine levels need to be adjusted. And some medications, they get cleared from the body and usually the clearance increases. So you have the weight gain, you have increase in the size of the uterus, increase in the size of the breast, and the the blood flow to your kidney and to your liver, and that all increases, that causes the levels to drop. So those blood levels need to be monitored and they need to be adjusted, because I would hate to see a patient having a seizure just because their pre-pregnancy level was okay, but they dropped their level during pregnancy because of this increased clearance. So as I said, there should be a pre-pregnancy proper planning, get the proper diagnosis. I saw a patient who had given birth to a kid who had some minor abnormality, had two thumbs in one hand, but was not the right diagnosis. That patient suffered from syncope, but was started on very old medication called phenobarbital and remained on that medication. So try to get the straight diagnosis, try to have a full handle on what kind of epilepsy you have. Is it focal epilepsy? Is it generalized epilepsy? Are you on the right medication for the right kind of epilepsy? Is there a room to lower your medications during the first trimester when most of the organs are formed, especially the brain, the spine, the spinal cord? And we're going to talk about something what we call neural tube side effects that can happen if we pick up a wrong medication. So try to find out that what are the safest medications that I can take during my pregnancy, which will not affect the fetus, which will be safe during breastfeeding, and the list goes on and on. Take folic acid always. What dose is very controversial. So usually we need about 400 micrograms of folic acid. There is only 50% which gets absorbed. So there is debate whether somebody should be on 1 milligram versus should be on 5 milligram. Excess of everything is bad in life, even hypervitaminosis. You don't want to have too much of vitamins, but usually people who have any previous history of congenital birth defects, they tend to take more like 4 milligram to 5 milligram. And there is no set dose, but usually 1 to 4 milligram. If you have a previous history of some fetus, who had some abnormality, we tend to go towards a higher dose. And it's seen again and again in studies that if you are seizure-free 6 to 9 months before seizures, hopefully you will continue very well during the pregnancy. But don't forget, there is a little bit of chance, 1/3 of the patients during pregnancy can have worsening of seizures, and they need more close follow-ups with their doctors. When a woman gets pregnant, as I mentioned, there are a lot of these changes due to hormones, but the drug levels also change. So there is a total level of drug that we measure in blood, but then there is a free level, which is mainly exerting its action on the body, which is circulating in the body. So sometimes it is important to distinguish that what is the total drug level, or what is the total free drug level. And usually most of the neural tube side effects that I said involving the brain, the spine, the spinal cord, they tend to happen either because of folic acid deficiency or vitamin B12 levels. Some of the patients who are on older medications may require supplementation with the vitamin K. And then comes that, like, how do we adjust these medications? Suppose somebody's blood level dropped during pregnancy, and I'm trying to increase that level to a pre-pregnancy level. 6 weeks after the delivery, I need to drop those medicine, otherwise patient will become very toxic on those medication. So postpartum adjustment of medication is very important. And how do you become the ideal mother to take care of the newborn, and how do you continue to educate your children as they grow, that if you have a seizure, how do they seek medical help? That's very important. So, there have been many studies more recently, as I said, in last 10, 15 years, which have taken this topic very, very seriously, and they have been studying that, what are the effects of these medications on the neurodevelopmental effects? What are the effects on my child's IQ? What are the effects on is it going to have some obstetrical complications or some fetal loss? So, I'm going to just quote this latest study that they have called Moniad study, where they looked at pregnant patients with epilepsy, and they had these many conceptions, and they compared it with 105 healthy compared women with these many conception. And the primary outcome of their study was like, look at the seizure frequency, increasing, decreasing, any complications during the delivery, and then, history of depression in women, and how it is having impact on the neurodevelopmental outcomes. And there are two types of birth defects, which we call congenital malformation. Some are major congenital malformations and some are minor. And they looked, several other French studies have looked at least these 10 different anti-epileptic drugs to see that which are the safest drugs. And, we are very encouraged by the prescription patterns, like how instead of writing older medications, more and more patients are on lamotrigine and levetiracetam or Keppra when they conducted these studies compared to older, like, Depakote or phenobarbital or Dilantin. But out of these different older and newer anti-epileptic medicines, the one main bad guy turned out to be valproate. Why? Because it increases the incidence of these neural tube defects, which if they are very, very severe, can cause a fetal loss, but can also cause some other problems in the spine and the spinal cord and the brain. There are a few major side effects. Whenever they require surgical intervention, those are referred to as major cardiac side effects versus a minor side effect that I just mentioned, that maybe 2 thumbs in one limb. So they looked at these different medications, and it looks like that these are the safest medications that we can advise to our patients. And it's like, to give you a summary of what I just said, the valproate or the Depakote and phenobarbital really have more of the congenital birth defects problem, and the newer medications are safer, and they carry a low risk of neural tube defects. Now, there is a thing called pregnancy registry. So if my patient gets pregnant and I tell my patient that I encourage my patients to have them do the pregnancy registries, then you can study the effect of these medications. If patients fail to register, whether it's Australian study, European study, North American, or Kerala study, or different countries, then you don't know what are the side effects of these newer medications. It's something he has to study. And I will not bore you with what are the results of these European or North American, Australian, or England and Ireland studies. But they came up with that Depakote is again a bad guy, phenobarbital again a bad guy. Now, what's the role of the folic acid? So on this graph, you can see that these are the medications listed. If you take folic acid, which is this solid line, what's this dotted line? If you're not taking the folic acid, there is increased risk of birth defects. What are those common defects that we were talking about that can require surgical intervention? And again, I don't want to discourage this audience. If you are on a safer medicine, we usually do not encounter these congenital birth defects. I do not recall a single patient that I can remember who did not have a healthy child. Despite all the complications, all the things we're going to talk about today, there are ways to detect any problems by doing ultrasound, by doing some blood tests to make sure that child is not born with any major defect. But some of the defects can be surgically corrected. So these midline defects called cleft lip and cleft palate, surgically corrected. If these valvular defects in the heart can be surgically corrected. But these are the ones which can sometimes be incompatible with life. As I said here, the malformation of the brain or spinal cord. And these can be definitely be helped with the folic acid. But the trend these days is, I don't remember any other colleague who is using Depakote at a high dose in this age and era, right? Usually either patients will not be on Depakote, and if they are so refractory that they are having seizures and nothing else is working, we try to minimize the dose of the Depakote. I do not have any evidence, much evidence of what we call keto diet. Keto diet is really in vogue. People love using it for obesity, for weight loss, for diabetes too, but diabetes mellitus and several other things. But keto diet is also used to help seizures. And basically, it's a restricted diet which is rich in fat, and it allows certain percentage of proteins and certain percentage of carbohydrates, and we really don't have any pregnancy registries to monitor the effect of the keto diet. So something that patients should know that we lack the evidence of the safety of ketogenic diet. Definitely it causes more bone loss with the keto diet. So now comes to the breastfeeding. Now, how do I monitor and do I advise patients not to breastfeed their children? So just look at the advantages of breastfeeding. It's the best source of nutrition. It improves your immunity. You name the ear infections, respiratory infections, diarrheas, all that is less with the breast milk, and at least 6 months of breastfeeding is definitely advised. Now, there definitely decreased risk to the mother if they breastfeed. They have less risk of breast, ovarian cancer, type 2 diabetes, and high blood pressure. I'm sure any woman who looks at this line would love to breastfeed, but it also has significant advantages and reduces the risk of childhood obesity, diabetes, eczema, asthma, celiac disease, and leukemia. There is also evidence that it increases the IQ. It definitely depends on the mother's IQ and the father's IQ. Usually maternal epilepsy is fetus with maternal epilepsy, it has more impact than the paternal epilepsy, but in terms of IQ, it definitely helps the breastfeeding. Now, which medications get excreted in the breast milk more than the other medications? Some of these medications are tightly bound to something what we call plasma proteins. And the excretion of the medications that the patient is taking is usually inversely proportional to the amount of the protein binding that drug has. And this is something that I don't want you to learn, but I just want to give you a flavor of that there are some medications which get excreted in milk more than the other medications. If it is very high plasma protein bound, less will be excreted. But if you have one or two other children that and you compare this child when you're taking a certain medication, and if that child is very sleepy, irritable, little jittery, then you can supplement some of the breastfeeding with top feeds also, right? And not only that, what are the medications which are relatively safe during breastfeeding? And I have listed a few here. And which has more side effect. So I would say more of these benzodiazepine like lorazepam and phenobarbital, all medicines have more side effects, and carbamazepine and phenytoin and valproate is more safer. Now, when we talk about parenting, there may be some common sense that we can use. Definitely, if mother is having a seizure and while she's holding a kid, any accidents can happen. So some common precautions that we educate our patients about is like, don't change the diaper on the floor. Don't hold the baby and then change the diaper. Things like when you want to bathe the baby, let daddy be present there. You can do it in the evening when there is other family member, if you do have that option. And while you're taking care of a newborn and you don't know what night looks like, what day looks like, don't forget to take your medications because you don't want to have more seizures while you're taking care of a newborn. When your baby sleeps, try to go to sleep because you want to catch up with your sleep. Sleep deprivation can trigger seizures. Take help from other people. I'm sure grandparents would love to play with your baby. So, have your husband do the top feeds, or you pump your milk and let the husband do the bottle feeding in the night. And then these are the common things that we use, our common sense, how to keep our toddlers safe, and educating your children. Like when they are at an age that they can call daddy and they can be on the speed dial, how to ask for family if mom has a seizures, or think about that, how do I keep it safe that my toddler doesn't walk out of the house while I am having a focal impaired aware seizures. So parenting can definitely be, we can definitely educate. And I'm going to kind of wrap up here, and we'll open more questions to our audience, and would love to interact with my patient who has volunteered her time and talk about, as we get older, there is always a thing called osteopenia and osteoporosis. So whatever my parents give as their genes to me determines if my mother has osteoporosis, I'm at a higher risk of osteoporosis. But other lifestyles, healthy lifestyles, if somebody does more exercise versus if somebody does weight bearing exercises, that also has an impact on osteoporosis. Some of the older medications definitely impair the absorption of vitamin D and calcium. So when we talk about bone, it's not like a column of bone, a pillar standing there. It's a live tissue which is constantly remodeling. And after 30 years of age, we don't make much more bone, new bone, but we try to break our bone more and more. The risk of osteoporosis is definitely more on women than men. And the risk is more as we get older. It risk depends on the genes too. But the risk also increases as soon as a woman reaches the menopause. So supplementing your diet with calcium, vitamin D is very, very imperative. There are certainly some drugs like a chronic use of steroids, which increases the risk of osteoporosis. But older medications like carbamazepine, Tegretol, right, or phenobarbital or dilantin, which we do not use that commonly, definitely increases the risk of osteoporosis. So older medications not good for bone. Relatively newer medications don't have much data, but maybe safer, but needs to be studied more. You should have calcium and vitamin D supplements. If somebody is adamant, no, doctor saying, this is the medicine which has made me seizure free. Don't touch my dilantin, don't touch my phenobarbital. You educate them, you do the bone density test, you follow the serial bone density test, and you ask them how to do weight bearing exercises and things like that. I think we are near the end of the talk, and we will definitely encourage questions. Ankita is going to help us as a panelist and is looking at the questions as they are coming. But I would just want to introduce one of my dearest, closest patient who has joined us from Florida to just, share her experiences with epilepsy. I know her for more than 30 years. And Buffy, thank you so much for joining us. I know Dr. Diaz had a pressing question she wanted to ask you. I hope it's not the tough one.
Thank you, Buffy. Thank you for being with us today. And
My pleasure. Thank you so much for asking.
In general, Buffy, can you share with us like how epilepsy has affected your daily life? And with this, I mean like, your relationship, your driving, your career, like how much has epilepsy affected you?
Oh, that's really dependent on where I lived at the time. When I first started having symptoms, I was in my early 20s and I was in Maine. And the second largest city in Maine has one bus. So it pretty much shut my life down. I was going to college and for theater. I'd just been accepted to NYU for theater, which is not an easy accomplishment. And yet, unfortunately, I had to drop out because not a lot of people are going to hire an actress who doesn't know her name during part of the day, never mind her lines. And so, I dropped out of college, went back to Maine for help. I was actually afraid I was schizophrenic when I first got epilepsy. There wasn't a lot of information about epilepsy. I just knew that people with epilepsy had the big shaking symptoms. And all I was experiencing was a deja vu syndrome that would make me vomit. And I knew the fact that this was happening over and over and that it was making me vomit, that something had to be going on. So I went to the doctor and he's like, "You're not schizophrenic," which was one of the nicest thing I'd ever heard. And they did some tests and discovered that I had seizures. And, over the years, it's gotten worse. I've had my different problems, but part of the problem is my ability to remember what's actually happening is so short that if I start a sentence, I can't always remember what my point was. But I dropped out of college. I did eventually get a BFA in sculpture, of course, using most of the tools that I like. I'm really not supposed to, but when I travel, I always feel like I should go ahead and let the people around me, especially since I'm usually traveling alone, feel like I should let the people around me know, hey, if I start acting weird, if I start speaking gibberish, it's fine. I'm not dangerous. If I start pointing at my head, just ignore it. I'm going to be fine. I'm just having a seizure. And at times I've almost been thrown off planes by the pilot because he was afraid I was going to have, your big typical what everybody thinks of as a seizure. And so it's been very frustrating, but I learned a long time ago, if you can't laugh at everything, you're clearly not paying attention. And I figured out ways around this. Quite often people tell me you can't do something and I figure out how to do it anyway. It's taught me to really figure out how to look at things from different perspectives. A lot of people in my life have gone ahead and taken advantage of this, where they figure if my memory is so bad, then that must mean I'm always wrong, which of course is not the case. And they've taken advantage of that, especially as a woman. Men in my life have just decided that I out and out must always be wrong. So I had to teach myself to learn to be okay with being wrong, even if I'm not, just to be able to survive and for my own stress level. It's really helped. And to be able to, when I do realize I'm wrong, if somebody's nice enough to just let it go and let me think I'm right, if I do think I'm wrong, 20 minutes, I think about it for the next hour. 20 minutes later, I might realize, you know what? I think I said that wrong. I say the wrong words a lot. If I do think I'm right and somebody lets it go and I realize I'm wrong, learning how to go back and say, you know what, I was wrong, that really helps also. It helps the people that are involved with you a lot. I found that if they know that you have no problem coming back and admitting when you're wrong, then if they just give you the free time, then it will all work its way out and be smooth. And of course, as soon as I was so busy listening to you two that I've completely forgotten everything that I wanted to say and in what order. So you're getting this.
You're doing great. We appreciate your help. You're doing great.
Thank you very kindly.
One question, Buffy, you gave me a lot of hard time in going on a newer medication. I know you were struggling with seizures. You had 5 to 6 seizures per day, easily, of different types. And we had monitored your brainwave, but you never took Tegretol for more than like maybe 200 milligrams twice a day. You remained on the baby doses. You tried several medications. What were the side effects that would dissuade you from trying something new?
I've actually at this point, I've been on every single medication. And unfortunately, I had side effects with everything. I wish, because it's funny you mentioned Tegretol, because currently I'm on Tegretol or carbamazepine, and I need to get off that. I do not sleep. I wish that when I started taking medications, I would look at what the possible side effects were and keep track and keep a little journal of what was going wrong. Because by the time I got through everything, really what happened is I pretty much just ended up staying on the last drug that I tried, even though that wasn't working either. I gained 10 pounds on the first medication. I don't know which one that was, but I gained 10 pounds. Originally, I was having 2 or 3 seizures a month. The first medication rose me up to 5 seizures a day. I gained 10 pounds. The second medication, Depakote, what an evil medication. I kept laughing when you were talking about the different problems. I gained 32 pounds in 2 weeks, lost half the hair on my head, shook like I had Parkinson's disease, and went like this continually. It was not pleasant. I went from 118 pounds to 172 overnight. and I had no control over it. And, it really kind of affected my ability to socialize because I was looking at one kind of man and they weren't looking at me anymore. But it all worked out. I had different things where, different body parts would just shake or whatever and do things. It was just so frustrating after the first two medications doing such horrible things to me. It was extremely hard I didn't want to find out what was next. It was horrifying and scary, which is why I was giving you such a hard time. But ultimately, I've tried every one of them. And, like I said, I'm on the Tegretol right now. I wake up sometimes every half hour on Tegretol because it dehydrates me so much. And the thing is, I didn't realize that I wake up every half hour to 4 hours to spray up my nose, spray in my mouth, put eye drops in, and usually to go to the bathroom because I'm drinking so much in the middle of the night. I will go through 2 of these, a 32-ounce cup in a night. One night, I refilled that 5 times in a single night. Just recently, I went in for a 5-day EEG, and for the 2 weeks, I went off the medication. Suddenly I could sleep and I wasn't dehydrated. And it did not dawn on me that the dehydration, because sometimes these things show up 2 or 3 weeks after you've started. They don't necessarily start immediately. And so I would just figure that it must be something else. And it wouldn't even dawn on me that, hey, this is what the problem is. But now I know it's absolutely the medication. And I can't wait to see my new doctor next and transfer onto to go through all of them again so I can document and figure out which one is least problematic.
Thank you, Buffy. Thank you.
Buffy,
Of course.
in this webinar, I think a good question for us to know from you is like, what are specific challenges or experience that you have had as being a woman living with epilepsy? What can you share with the audience as?
Well, as I said, I was in Maine at the time and there weren't any buses. So my mother would pick me up to take me shopping. My father took me to work to his house where I created catalogs for used car dealerships for him in his house. And so I did not have, with the first time I was told I couldn't drive, I had no ability to get out and socialize and meet any kind of a mate. It was just horrifying. And the second time they told me I couldn't drive, I moved my butt back to New York City where I could at least get around. And yes, going around on a subway is dangerous. There were one time on my way to seeing Dr. Singh, I was standing up on the subway. The next thing I knew, I was sitting down and everyone was staring at me. And I was on my way to see the doctor. Another time I was walking down 6th Avenue coming home from TJ Maxx, and the next thing I knew, I was in an ambulance. I went down with my Christmas gifts, and my first words out of my mouth were, I had a seizure, didn't I? And the people on the ambulance were shocked that I could even speak. And, I ended up, because of the medication causing me to put on so much weight, and I couldn't see anybody. I didn't end up meeting my husband until I was 45 years old, and I met him at 52. And fortunately, I have the ability to be grateful for all of the hard times that I had with the seizures and the medication, because without them, I wouldn't have become the perfect person to be so perfectly matched to him. In the same way, I'm grateful for his ex-wife, because without his time with her, he wouldn't have turned into the perfect person for me. So seizures equal ex-wife.
So,
Thank
Buffy,
you.
sorry to interject. You had a very, very high seizure burden. Your seizures based on the EEG monitoring were coming both from the right as well as the left side. But we thought predominantly your seizure focus was right side. I know you tried VNS, but there are other modalities that were not available when I took care of you. But
Yes.
with responsive neurostimulation and other things which are less invasive, which can be done for bilateral cases if they are sensitive to medications. But you did have some structural abnormalities on the MRI. And one of the neurosurgery consultation mentioned that maybe we can partially reduce, if not completely cure your epilepsy by resecting a certain amount of tissue which was abnormal. What were your reservations? I know this is not an epilepsy surgery kind of a webinar, but we did offer you surgery, but you didn't go for it. Can you tell me your myths about epilepsy
Well,
surgery, your fears about epilepsy surgery?
if I had had a little more success with medications, I don't think I would have been as horrified. I am very afraid. Unfortunately, the people doing surgery are human. And with the medications, if they don't work, we stop taking the medication, we try something new. If the surgery doesn't work and it, on the off chance that it makes me worse, there's no going back. And at the time, I was extremely lonely. The people on the show Friends were my only friends because they were in Maine. Those were the only people that I saw that were my age. I honestly would have been extremely, extremely depressed and suicidal if things had ended up becoming worse, because there was no way of going back. And at least on the medications, I had a way to go ahead, and I knew how to maneuver it. I knew how to manage it. And that little bit, when you develop epilepsy, so much of your power and your ability to control things just goes right out the door. And at least, you know, the fear of losing that little bit of power was way too horrifying. It was nothing that I was really wanting to look forward to. So there.
Thank you so much, Buffy. Really appreciate your time. Let's see, I was enjoying talking to my old friend, my patient, and
I
Dr.
love you,
Diaz,
Dr. Singh.
and Dr. Diaz was nonstop working, looking at the questions that we are getting through our audience. So let's see if we can tackle.
Yeah,
any
let's
of
go
the-
to questions. Thank you so much, Buffy. A pleasure to
My
have you.
pleasure. Thank you.
So we're gonna open up to
Yeah, if
questions.
we have it in the chat or
I think.
Hi, hi, Dr. Singh. Hi, Dr. Acosta Diaz. I can take you through some of the questions that we are receiving through the chat.
go ahead.
So-
Anuradha.
There is a question where this person is asking if epilepsy predisposes patients to accidents, or should they stop driving on certain days when they have epilepsy?
Yeah, so I can take this question. So driving with epilepsy depends from state to state you live in. There are some states which are more liberal and allow you to drive 6 months afterwards. But driving is a privilege. You don't want to be driving while you're having a seizure. So if your epilepsy is not well controlled, it is illegal to drive. There are some states which will require the doctor to report it to the Department of Motor Vehicles, but there are a lot of states which will have their own medical unit, which makes their own discretion that whether somebody can drive or not. If I feel that my patient is reliable enough, trustworthy, taking his medications or her medications properly and is doing well, I do fill up a form, and then it is the medical unit that reviews that thing to see if they're safe. But like I'm talking about New York State here, if you're seizure free for more than 1 year, you can drive. There are some exceptions too. If you have exclusively nighttime seizures, or if you have seizures which have never impaired your level of awareness, then legally you can drive. And I'll stop there.
But the most important thing as well is to discuss with your healthcare provider. Like even if you have been seizure free for a year, you have to discuss with your healthcare provider before driving. But you're going to be able to drive.
Thank you for that answer, Dr. Singh, Dr. Acosta Diaz. There's one question about pregnancy. Like, what is the biggest challenge to pregnancy? And this person heard this phrase, "forget about your pregnancy," and they could not understand what it meant. So could you share something about that?
So there are some myths that we have to debunk. That's why we are doing this patient education seminar. 90% of the children born to mothers with epilepsy are healthy. There are some risk of congenital birth defects even in general population. If you have a proper planning of having a baby, and if your seizures are under well control, and if you're not on those older medications, you have almost comparable risks to general populations. that requires proper planning, that requires going on the folic acid supplementation, as we talked about. And there are many, many diagnostic tests which can determine if there are any risk of congenital birth defects, like some people do amniocentesis, some people do serial ultrasounds. There is a maternal serum alpha protein test that you do. But remember one thing, that most of us, as these studies are coming out and we are understanding that which drugs have serious neurodevelopmental side effects on the fetus, we are not using those drugs. We are using more and more safer medication. So the patient that I mentioned, we are talking about New York City, the neurologist tells the patient, don't get married, don't have children, forget about the pregnancy. That was a wrong judgment on that part of the neurologist. And I think you have to debunk those myths.
Thank you for answering that, Dr. Singh. We have a question which the person is asking, is catamenial epilepsy correlated with catamenial migraines? And should patients just take triptans as precautions?
So we do know that both conditions are because of fluctuating hormones during the cycle, but remember, these are two different conditions. Catamenial epilepsy is seen in patients that have epilepsy and has that increase of seizure frequency during a specific part of the period of the cycle. So the treatment is different. These are two different conditions. And remember, in catamenial epilepsy, we have to treat the epilepsy. And then there's different things that we can do during a specific part of the period, but it's not the same condition. Triptans are part of the treatment of migraine, and I know some of the newest medication are used as well for patients with catamenial migraines, but it's two different conditions, so the treatment is different.
Yeah, migraines is different from epilepsy. It does have some similarities. Seizures happen and then you're normal, migraines happen and then you're normal. But they are different, as Dr. Diaz said. These are two different problems, and triptans are not going to help epilepsy part. And my strategy is to treat that as like, okay, take a little bit of extra benzo, take a little bit of extra tablet. Maybe we can use some kind of a rescue medication at home. If you have a tendency to have one after another, a few cluster of seizures around your menstrual time or your ovulation time, try to use those nasal sprays so that you don't have to go to the emergency room. But there is a whole wealth of these hormonal treatments. If you are near the end of your cycle, and if your levels of your progesterone are low, which is a protective hormone, as Dr. Diaz mentioned, then it can be supplemented. You can supplement it naturally. You can use synthetic progesterones. I remember vividly that Buffy, when she saw me, she said, my seizures are related to my hormone. Maybe doing some kind of a drastic surgery and getting rid of the uterus will be helpful in controlling my epilepsy. So they're different diseases.
Thank you for answering that. There's one more on catamenial seizures. This person is asking, what if a person who has epilepsy has an IUD? How would the doctor determine if the seizures they are having are due to their catamenial epilepsy? And during a convulsive seizure, can their IUD get dislodged?
So the IUD is one of the safest method of contraception that we use. Even though some of them has progesterone, it does not affect the seizures. So there's not really a contraindication of using an IUD if you have catamenial epilepsy. And I haven't heard of any case of an IUD being dislodged because of having a seizure and you getting pregnant. So I don't think that's going to happen. That is implanted in a way that is not going to move just because you're having a big seizure or a generalized seizure.
Yeah, with some use of some IUDs, there are sometimes that women will report that they are no longer getting their regular periods. That has been reported with the use of IUDs. There are also, when they remove the IUDs because they want to get pregnant, depending on what type you're using, sometimes there may be delay in conceiving after the placement of the IUDs, but they are one of the, safest, method of contraception with low failure
Interaction,
rates. The
no
the
interaction.
biggest indicator of a failure rate of a contraceptive is some kind of a bleeding in the middle of the cycle. There, the woman knows that they're in trouble. But IUDs are considered very, very safe.
Thank you for answering that. An attendee is asking that their daughter was recently diagnosed with epilepsy and they are under a certain medication and she has put on weight. Is there anything she can do to reverse her back to her original weight while she is on her epilepsy medication?
So there's a few things. First is like, I'm not sure what is the medication and if the weight gain is because of the medication, but we do know that there's certain group of medication that this is a common side effect. I always, and as a pediatric epileptologist, I have to talk a little bit about Depakote because we have been saying only bad things about valproic acid, and it's a medication that we use as a pediatric epileptologist more than the adult. Because it's a great medication, it's an old medication that treats different type of seizures, and we do know side effects. And I always tell the parents of my patient, it's not the medication that give you the all the extra pounds, it's as well your habits and what you're eating while you're taking the medication that is well known to have these side effects. In the other hand, sometimes we have medication that as a side effect, weight loss is part of it, and in that group we have Topamax. So sometimes depending on the case, depending on the type of epilepsy that the patient has, we try to combine. But again, it depends a lot in what case and what is the situation, what the medication is used. What I really want to mention is I do not stop the medication without discussing with the doctor first, because it's not so easy, but sometimes we can cross taper because we want our patients to be happy and we don't want additional stress, and the epilepsy per se is already given. So we always try, if there's a significant side effect, we're going to try to cross taper with a different medication that treats the type of epilepsy that the patient has.
And as you mentioned, migraine and epilepsy are very common, and there are some definite medicines which are used both for epilepsy and migraine at different doses. But then you can say, okay, I'm going to use some prophylactic medicine for this patient who has migraine as well as epilepsy. And if that patient is little on the heavier side, has higher BMI, you try to pick up something that Dr. Diaz mentioned, a Topamax, which has weight-losing properties, doesn't cause significant weight gain. And that is something worked beautifully for migraine, but also works for epilepsy. But depends on what is the seizure burden of that patient and what side effects they have on the dose that is sufficient to control their seizures. Because at very high doses, usually anti-seizure medicine cause more side effects than beneficial effect. Most of the medicines, if they work at moderate doses. If we are forced to go at a higher dose, usually then we encounter more and more side effects.
Thank you for answering that. There's a question about the scary side effects of epilepsy medications, and the attendee is looking for they also want to know, are the side effects same for everyone who has epilepsy, or do they differ from people to people?
Can you repeat the question, Ankita? The first part was not clear.
They're asking, are the side effects related to epilepsy medications same for everyone, and why epilepsy medications can cause such side effects?
Right, so the newer medications have less side effects. Are they better than the older medicine? We don't know. If the incidence or the prevalence of the drug-resistant epilepsy keeps going down. So I want to make it very clear, 2/3 of the patients that we see do very well. They are on one medication or they're on two medications, they're tolerating it well, and they are seizure-free. In those patients, we do not need to talk about some of the things that I was trying to ask Buffy. We don't need to talk about surgery if they're doing well and if they're tolerating the medicine. But some patients are very sensitive to the side effect of medicine. And based on if they have something that can be surgically removed, instead of being on those one or two medicines for the rest of their lives, it's better to go see an epileptologist or go to a level 4 epilepsy center, have a proper diagnosis, and then get treated or think about medical options, dietary options, or surgical options. It's easy to take a medicine every single day, a pill in your mouth, versus it's complying with the ketogenic diet, which restrict certain amounts of proteins or carbohydrates for the rest of your life. That being said, if it works for you, something you can easily adopt and keeps your seizures under control, go for it.
And another thing is like whenever we're starting a patient on medication, we look at common side effects. And I want to emphasize most of the patients do well. Most of the patients tolerate medication well. It's not the most common thing that the patient has a bad side effect. And as well in this webinar, we have to mention again, most of the patient has a healthy baby when they decide to get pregnant, okay?
Thank you for answering that. I'll take one last question as we are very close to our time. If there's a woman in your care who wants to get pregnant and she wants to get in touch with other women with epilepsy, is there any peer support program?
Definitely, we have patient champions, and the perfect example is Buffy, who said that if I can have any impact on somebody's life, sharing my life journey with epilepsy. So we do have volunteers, like we have volunteers who, have dedicated their lives in educating people about epilepsy, in supporting these kind of seminars. And similarly, we have people who are patient champions. So we do maintain a list of people when we see that enthusiasm in their personalities, that these people have time and willingness to go to any length to help the families. We do keep a track so that they can definitely talk to people. There's a lot of information on Epilepsy Foundation too. And if you go on YouTube, there are many patient education.
And it's in the National Registry as well. If you
Yeah.
decide to get pregnant, there's
Yeah.
different things, yeah.
And feel free to reach out to us. We are happy to share our contact information, our number, and you can share, Natasha, yours office number. But our office number you can put in the chat is 212-241-2627. We have more than 13 adult epileptologists. I haven't kept the count. We are recruiting more adult epileptologists and peds epileptologists. So we will feel free to ask any other questions if you want to come for a consultation.
Yeah, it's sad that we won't be able to answer all the questions
Yeah,
because we're
yeah.
running out of
Time, yeah.
Thank you so much for answering these questions, Dr. Acosta Diaz and Dr. Singh, and having this wonderful session for women and girls out there with epilepsy. I'm sure this was helpful for them.
Thank you, Ankita, for arranging this. I know you did a lot of efforts to make this happen. Thank you, Buffy, for being there for us. And
you.
I hope you guys learned something. We definitely will inform you of more patient education seminars in the future. Thank you, guys. Bye-bye.
Bye-bye.
Thank you. Bye.